Hi, thanks. Welcome back again. And we're just thrilled that you guys can be a part of this series. This is the third of a 6-part series and focused on all things clinician and staff burnout at health centers. So ACU has been around for about 20 years, and we are a national nonprofit focused on really just all things workforce and the recruitment and retention of a transdisciplinary team solving the access issue. And we have a national cooperative agreement with the Bureau of Primary Health Care. And our national cooperative agreement is called the STAR Center, and that stands for Solutions, Training, and Assistance for Recruitment and Retention. We develop and distribute a ton of free tools and resources, such as this webinar series. And we have toolkits and tools and all sorts of downloadable resources on our website. So go to chcworkforce.org and you can download all the things there. And if you haven't had a chance to go there to our website, please feel free to do so, and we would be more than happy to answer any questions you might have when you're tooling around there. I am Suzanne Speer. I'm the Director of Workforce Development here at ACU, and I spend the majority of my time working on STAR Center activities. And we also have some other fabulous people that are on our STAR Center team. We have Allison Abe-Sacra, and she is our VP of Training and Programs. She is not on this call today, but she has been with the ACU and the STAR Center since its inception. And so anyway, she's a great contact for you there. And also we have Mariah Blake on the line. That's the voice that you heard telling me I was on mute just a minute ago. And Mariah is our program manager, and she keeps everything running and makes sure that I'm not on mute during webinars and just generally keeps everything going. And so that is the core team at the STAR Center. Before we dive into content today, just going to go through some webinar housekeeping items. We are recording this webinar, and it will be available for download on our website after this. So if you have some colleagues that weren't able to attend, or if this is the first of the series that you have been a part of and want to go back and listen to the others, they're all available on our website for you to download. Feel free to ask questions as we go along. We are going to answer all questions at the end, so just FYI that that's going to be the way we do it. But please go ahead and put those questions in the questions box as we go along so you don't forget your questions, because sometimes if I don't write things down when I'm thinking of them, I do forget. So anyway, feel free to put those questions in the questions box as we go along. And don't forget to have a little fun. This is a really important topic, but it's also something that it's kind of the more you know, the better you are. So we really are excited that you're here with us today. Just a few goals for the series. We are, as a part of doing this series, we really are emphasizing the importance of and also addressing burnout within your organization. It is something that is a very real topic and affects everybody from physicians and providers all the way down to front desk staff. So it doesn't really matter what your role is in a health center. It can really affect everybody. And throughout this series, we are going to be examining different approaches as well as different perspectives to the burnout, to the topic of burnout. And we're also going to be learning strategies to address burnout. And as I mentioned, we are going to be having different perspectives. So we have had a national perspective from ACU and the STAR Center the first time. And last time we had a physician, and today I'm thrilled that we have a nurse practitioner on with us to give some of her perspectives there. And Cheryl Fattibene from the National Nurse-Led Care Consortium is here with us today For those of you who are not familiar with the National Nurse-Led Care Consortium, they are another NCA, another National Cooperative Agreement holder, and we are absolutely thrilled to be partnering with them on this webinar series. Just a little bit about Cheryl. She is a family nurse practitioner by training and has about 30 years of clinical and leadership experience in the healthcare field. Her clinical focus has been in underserved areas and vulnerable populations, so she knows a lot about this subject. She currently provides clinical oversight for the work being done at the National Nurse-Led Care Consortium regarding state and national nursing policy, advocacy for nurse-led care, and educational programs for upcoming payment reform. She earned her bachelor's from the University of Connecticut and a combined master's in nursing and also in public health from Yale School of Nursing and Medicine concurrently. She is a doctoral candidate right now for nursing leadership with the nursing leadership track at Regis University in Colorado. And with that, I am thrilled to turn it over to Cheryl. Thank you so much, Cheryl. Go ahead and take it away.
Well, thank you. Thanks, Suzanne. And I wanted to thank ACU for their support in this work. I have worked with ACU all of my professional life and really do enjoy the work. And it's really just an important part of the work that we all do as healthcare providers. So before I get started today, and I thank you for that introduction, I just wanted to talk about the work that I'm going to be sharing with you today is a collaboration with a number of different organizations. So ASU, Arizona State University, has got an interprofessional practice education and research group that helped with the development, as well as the National Center for Interprofessional Practice, two excellent organizations if you are looking to further your practices in more of an interprofessional approach, as well as the American College of Physicians, which is right here in Philadelphia, where I am, who partnered with me to do this work. And we have brought this work out nationally. So here are the objectives for today and the things that we will be going through. First is to define burnout and its impact on all providers, practice operations, and as well as the bottom line. Recognizing signs of burnout, both contributing and protective factors. And then finally, the use of the patient-centered medical home model as a framework for finding joy in work. So a little bit of background about this work before we get started, because it's important to frame how we got here. So we've had changes to our healthcare system, and I know I've certainly seen many of them over the last 30 years. And it's changing rapidly in an effort to deliver better care, improve health, and also to lower costs while providing care for an aging population with high rates of chronic disease and also comorbidities. Among some of the changes that we've seen in clinical practice are payment and delivery models and approaches that have changed over time, an electronic health record, which didn't exist when I first started in practice, patient portals where patients can access their own records, and then publicly reported quality metrics. All of this change just kind of lays the landscape for how we are seeing the provision of healthcare, how it's given, how it's documented, and also how it's reimbursed. So I think the thing that we know about healthcare is that change is part of the work that we do each and every day. So why talk about burnout? So this to me was the important question in thinking about this work, about why it's important. And there's many different reasons for that. But I think first and foremost, for those working in healthcare, myself included, I think we've seen the numbers of providers we've lost over time. So we need to address burnout for that reason. It's also kind of the elephant in the room and the thing that isn't talked about when you have a dysfunctional organization or when you're feeling that compassion fatigue and you're not quite sure why you're not your best on a day-to-day basis. And the lastly is to bring back the joy and balance in our work. We all came to this work because we enjoy the work. hopefully we enjoy the work or have enjoyed the work, and that's a place we want to get back to. And it's so important for both us and our patients to get there. So when considering the amount of mounting evidence around provider burnout and how it adversely affects the quality of care, these studies that I show you here show findings that suggest highly prevalent and a systemic problem that's really threatening the foundation of the U.S. medical care system and the system that we all work in. And these are all studies that you can take a look at for yourself to see how the rates have really gone up over time. I think what's most alarming is the physician rate of suicide in the United States. So what is burnout? If we go back and we look at the definition of it and how it's been defined in the past, so when we're in the throes of a full-fledged burnout personally, you are someone that can no longer function effectively on a personal or professional level. However, burnout doesn't just happen all of a sudden. You don't just wake up one morning and all of a sudden you have burnout. By nature, burnout is something very insidious. It creeps up on us over time. It makes it harder to recognize when we have it. And our bodies and minds give us warnings. And if you know what to look for, you can recognize what's going on before it's too late. So what are the signs and symptoms of burnout? And they may look similar and may look like things that you've seen before about just general physical exhaustion in terms of the insomnia, lack of concentration, appetite, anxiety, and depression. And it may manifest itself even as anger. Emotionally, it plays a tremendous toll on what we do from a day-to-day basis, and it may not be just at work. It might be at home as well and in other things that you do. Just things don't feel as good as anymore. You feel more isolated, more detached. There's sort of a lack of joy in general in life. And then lastly, and I think more pervasive, is this feeling of being ineffective, feeling that what we do no longer matters, and a sense of apathy towards patients and maybe even towards our family members. What often gets noticed by managers and within the organization is a lack of productivity, inability to do what you had done before at the same level, and generally poor performance. So it may be something that an employer may identify and point out to you, and it is a message that's often difficult to hear. So the signs of emotional burnout and overall burnout are really built of these three things. So we have the emotional exhaustion, or the feelings of being emotionally overextended and exhausted at work. The depersonalization, sort of a stepping away from or feeling immune or impersonal towards both recipients of your care, treatment, instruction, or just those around you. And then lastly, on a personal level, the effect of competence and achievement and how that goes down over time. One of the things that we've noticed when this begins to happen is there's quantifiable things that can happen within the practices that we work in. The most concerning of which for me is the medication errors, that when we're not focused and present with the work that we're doing, we do tend to make more errors. There may be delays in treatment or incorrect documentation in a chart. And again, these are all signs and small signs, but things that when you put them together, they begin to show a pattern. Often patients are dissatisfied. There may be disconnect between that patient and provider communication that's going on. Again, it's kind of insidious. You might not always feel it, but you may be feeling that creeping up some of the time. And then personally, we talked about this before in some of the ways that we deal with it. Through anxiety, it may cause stress at home, make things a little bit more difficult for you at home, as well as some substance abuse. And we do know that that is something that providers are at risk for within their organizations, is abuse of a number of different types of substances. So when considering all of this, and looking at what we're talking about today, it's really no surprise when we look at this that 50% of our clinicians are concerned about lowered standards of care. They express irritability, They may be calling out of work. They may feel unable to get through the day. And also the one I thought was interesting from a provider standpoint, when you're feeling that you're having trouble coping, that your prescription rate tends to go up, which I think is interesting too. When you think about, needing that quick fix, get the person off the phone. So that might be something to take a look at as well, about what's going on with prescription writing within the clinic itself. While the healthcare industry faces a critical shortage of available workers, there's another challenge that's looming. It's the competition between healthcare providers for consumers, which is also on the rise. And as we see more baby boomers, there are more patients entering into healthcare and need our services even more. In such a tight type of market, successful healthcare organizations are those that understand the relationships between their employment practices and the retention of key talented employees, as well as patient satisfaction. Higher satisfaction scores for both the provider groups and the patients were consistently associated with a greater percentage of patients experiencing continuity of care, lower patient no-show rates, more efficient use of ancillary staff in providing direct patient care, which is a team-based care model, and also more reasonable changes that could be expected at a follow-up visit. And while the bottom line is not the reason that we're in healthcare, burnout is affecting our bottom line in those ways. So this graphic here, it's a little bit busy, but I just want to tell you a little bit about it. It's based on a 2010 case study by Willis Towers Watson about burnout and its economic effects and this is hospitals in particular, so for hospital networks. So there's a direct relationship between employee opinions and patient satisfaction. So specifically, employee engagement, so being engaged in the work that you do, and satisfaction with pay and benefits were related to patient satisfactions, both with their waiting time as well as the courtesy and concern shown to them by the hospital staff, the facility's physical conditions, and the staff's technical skills and their willingness to recommend the facility to others. In other words, when hospital employees were more engaged, as defined by teamwork, empowerment, and career advancement opportunities, they were more satisfied with their pay and benefits. Their patients believed that the care they received as a result of these staff, and they were more willing to recommend the hospital as a place for friends and family to go to receive care. Changing employee perceptions of pay and benefits can be very difficult. And for this reason, the most effective way for hospitals to influence patient satisfaction and ultimately influence whether or not a patient would return and recommend others to return to their facility is to focus on employee engagement, which often gets lost. Teamwork is front and center to healthcare staff engagement and should be considered a facilitator to improving your bottom line rather than a barrier. So as we can see here in the graphic, the more engaged, we notice that courtesy and concern go up, waiting times go down, and physical conditions are better because there is a buy-in from the staff to take care of the physical space as well, not to mention taking care of their patients. So let me go back here. So identifying techniques to address burnout. So I wanted to talk about this because burnout really happens at both the personal level, but also at an organizational level. And you really need to be addressing both in order to be successful in identifying this issue and then coming up with ways to be able to deal with it. So first, let's talk about promoting personal well-being. And I know that there are many people who will look at this and say, you know what, I don't have time. I don't have time for much of what's on this list. But what I would say to that is, at the very least, the bottom three with sleep, eating, and exercise are key in order to maintain your physical health. So those are extremely important, and those are the things that tend to fall away when we're feeling the pressure at work and we're not feeling the joy at work. So keep these in mind for promoting well-being, and think of things that you may be doing now that help to promote your well-being. And we're going to talk about that at the end and give you an exercise of ways to be able to identify those things so you can identify them and figure out how you can actually integrate them in to your life so that it can help with your well-being both at home but also at work. So employee engagement to reduce burnout is absolutely essential. Employee views of employment, career advancement, and teamwork will influence engagement. Employee engagement is a key predictor of patient satisfaction, as we mentioned before, leading to an increased likelihood that patients will recommend both you and your setting to others. And that's what we want. We want to provide good care so that others will come to be able to receive the care that we give. Improving engagement contributes to improved performance of the staff also. It enables greater professional productivity with lower turnover rates. Joy in work, in turn, improves the patient experience, outcomes, and also safety, as we saw on the slides before, with decreasing medical errors and also decrease in prescriptions, and results in substantially lower costs, but moreover, better care for our patients, which is the key and what we want as healthcare providers. Building targeted interventions, such as team-based care initiatives that enhance employee engagement and patient retention, will benefit both the health setting's bottom line as well as provide contributing factor against employee burnout. And I'm going to talk about that more on this slide. So we are looking at patient-centered medical home model and some of the emphasis on things that will contribute that have protective factors to burnout. As per the patient-centered medical home model is an emphasis on quality care and team cohesiveness, or team care, team-based approach, strong communication skills, so good communication between all of the staff, equitable work and distribution, so knowing what your work is and making sure that it is distributed equitably so people do not feel as if, some work harder or more than others. And lastly, autonomy and organizational decision making. These are all parts of the patient-centered medical home model that are inherent and are also protective factors and will help to not only identify burnout, but provide a way to be able to avoid burnout in the future. And again, as I said, these are all characteristics of that patient-centered medical home model as well as a team-based care approach. So if you're already using a patient-centered medical home model, you have the infrastructure baked in to be able to address the burnout issue. And if you do not, I would encourage you to look at that as a possibility either for your organization or just to use some of the take-home messages that they have around ways to be able to deal with this important issue. So here's a little bit more about the patient-centered medical home for those of you both who work in it and also for those of you who may not be as familiar. These are some of the tenets of a patient-centered medical home as per the NCQA. So team-based care and practice organization are front and center in what's important in achieving patient-centered medical home status, as well as all of the other things listed here around support and care coordination and quality measures. But the team-based care really is one of the most important parts of that model, and that's what we're going to focus on for the rest of today's talk, is how team-based care and improving communication can help within your settings. So again, talking about the patient-centered medical home, and we have that here on the left, and thinking about a team-based model of care. So team-based care can mean different things in different settings, but I wanted to give to you what the NCQA has listed as team-based care models of care. So we have, again, structure and responsibility, collaboration, inclusion of the patient and the family in governance, your EHR, and so on. So again, team-based models of care are inherent in the work of those that are working in patient-centered medical homes. And again, really gives you the framework to be able to move forward on bringing this back or focusing on this within your facility if you may have gotten away from some of these basic tenets of the patient-centered medical home. So next I wanted to talk about teamwork and how we achieve teamwork, as well as identifying what the culture of work is that you work in right now, and also looking at quality outcomes and quality metrics for you to have a way to be able to maybe, introduce some tests of change to change things organizationally that could help improve team-based care as well as teamwork. And by default, that also helps to bring the joy back in work. So one of the first steps that we encourage every organization to do, and we at NNCC teach on this model of care nationally, it's been very well received. And it's sometimes good to take a step back organizationally and relook at your organization and say, is the patient, the family, and the community at the center of the care that we provide? So the next step is to look at who are the members of your team. And as you can see here, we have some of those roles filled in. You may have some of these roles, you may have these roles and other roles. So a starting point in understanding your team is figuring out who's on your team. So this is an exercise that you can do within your organization, is to define and identify who is part of your team. Once you've done that, you want to know how you can become a high-performing team. And we're going to take the next couple minutes to talk about that and why a high-performing team actually leads to improvements not only for your patients, but also to your staff. So what are the characteristics of high-performing teams? And this is not something that's subjective. We have some objective data that I'll be sharing with you about what makes a high-performing team. Also, what differentiates teams that meet their goals from those that do not? How are they different? And how can you become part of a team that meets their goals? So this is what the research says about teamwork, and everything that you're seeing here today is based in research that's been done on this topic over the last couple of years. And there is a large and growing body of research about this and about what makes high-performing teams. I believe in part because the way we look at care and the teams we have changed dramatically over time. So very important to start at the top with communication when you're thinking about an effective team. How do you communicate? Do you integrate in cultural differences to your communication within, now we're talking about within your teams of care, not so much your patients, but working together. And is communication a foundational aspect of the work that you do within your teams? How do you communicate? When? It's important to know that because communication is best received when it's ready to be received. So that's something that you need to think about. Coaching and leadership, extremely important. Many of you are in coaching roles right now. Many of you are charged with creating a culture of teamwork. But what does that really mean? How are you leading? And how are you coaching? And how are you dealing with that amongst the staff? Are you in a leadership role where you may be able to mentor and coach others? Or are you in a role where you're on the floor, in the office each day, and maybe taking on someone to mentor or coach along with your day-to-day work? Cooperation is extremely important, and it's what brings us all together. We often describe our places of work as our second families, and cooperation in work works very much the same it does as cooperation at home. So we know that when you have a group that's cooperating with shared goals, things tend to get done better, and you enjoy doing them more when everybody is on the same page. Cognition is another issue to think about in terms of effective teamwork. It's a shared mental model. So do you know what other people do? Do you know what the roles are within your organization? I know this may sound elemental, and yes, I'm a nurse practitioner, and yes, I know I have an MA, and this is what the MA does. But it would be interesting to ask them. Ask the people you work with what their roles are and what they identify as being their responsibilities, and you may be surprised. And can a member of your team accurately portray what you do on a day-to-day basis? Is there anyone besides maybe your supervisor or manager who may know what you actually do on a day-to-day basis? And if you're like so many providers out there, you're probably doing what you're expected to do, plus much, much more. So something to think about. And then finally, probably the most difficult part is conflict management. So how does your organization deal with conflicts? How does it deal with conflicts internally between staff? What are the tools and resources that you have within the organization to be able to manage conflicts? Conflicts can destroy organizations, it can destroy relationships, and they are something that take up a tremendous amount of time. So it's really important to have a game plan in place when there is conflict, even when it's low level, to address it, to call it out, to identify it, and deal with it before it turns into something that is more pervasive. And lastly, coordination. So this is the difference between a team working together to get a team approach versus task work. So it's coordination doesn't mean just ticking off the boxes on your to-do list each day, but how do you do it together with the help of your team? So teamwork is also managing life with other people, both inside and outside of work. So again, very important points, things to think about and take home when you're thinking about them and take back to your practices. So some of the core principles from the Institute of Medicine, which is now the National Academy of Medicine, about teamwork really reinforces what we had just talked about. So in order to have a high-performing team, these are some of the things that must be there within your organization in order to have that high-performing team. So you all have to share the same goals. The roles of everyone and what they're doing needs to be clear. I want to underscore here mutual trust and how important that is. If you don't have trust within the organization, it's very difficult to feel as if you're part of a team. We talked about effective communication. And then there are ways to be able to measure processes and outcomes, looking at this team approach that are quantifiable. And we'll talk about that in just a few minutes. So defining teams and team responsibilities. We had talked about this before, that all roles are understood and respected. One thing I would suggest all of you do is go back and look at your job description and see if it actually reflects the work that you do. That would be a really good starting point for everybody. If it does not reflect what you do, probably time to talk with your supervisor or manager and consider rewriting that. And it's a good opportunity for both you and a manager or a supervisor to get on the same page about what it is that you do and what the expectations are for your role. So again, scope and responsibility should be really explicit. It's often not in healthcare. It often has to do with who happens to be there at the time. Things happen on the fly because of need. Sometimes you're down staff and you have to do what you have to do. But if you can clarify that scope and responsibilities for every role and have it be very explicit, it will cut down on hurt feelings between staff members who feel like they may be doing more than everyone else or tapped a little too often. And then lastly, each person needs to really understand why they make a difference. What is it that they bring to the organization that makes a difference in the work that you do on a day-to-day basis? And it's just a small example of that is I currently work with medical assistants when I see patients, and when they have gone the extra mile to check the vaccine status for me and offer up that information, I thank them for that, because that's one more place in the chart I don't have to look, and they can help me keep on top of my work. So look for small things like that where you can thank people for the teamwork that you do together. So a little bit more about teamwork, and this is a little bit away from the field of healthcare. This is actually an article on social supports and the perceptions in a social psychology study that was published in 2008 in the Journal of Experimental Social Psychology. And what they did here was they asked people to stand at the base of a hill and to estimate how steep of a climb they thought it would be in order to walk up that hill. And the one thing that they found is that when people were standing at the bottom of that hill alone, that hill looked very steep. When they were accompanied by a friend or someone they trusted, even one other person, that hill suddenly looked more manageable and a lot less steep. And I know this sounds maybe like a little bit fuzzy in terms of gathering data, but what it points out is that when we work together, we feel better about the work and the work seems more manageable. And that was the goal of the study, to see how we're different alone than we are together. And there's definitely a psychological difference in feeling as if you're valued and part of the team. So that's just something to keep in mind. Role clarities, again, we talked about this. Licensure, scope of practice are particularly relevant right now for nurse practitioners nationally. There's a lot of changes underway looking at scope of practice. I would encourage everyone to be sure that, one, you're working to the top of the license that you have, and depending on your role, just be aware of delegated authorities and be wary of delegated authority from another provider. That can get you sometimes into trouble in terms of crossing lines where the work may not be yours to do. So if you have a question about whether or not it falls into your scope of practice, please check in. Don't just do something because someone else is asking you to do it if you feel uncomfortable or you feel like it may be out of your scope of expertise, but also your scope of licensure. So next I wanted to talk about looking at the team that we have now. So we've talked about communication, we've talked about putting the patient in the center. But now we need to kind of take a step back from our organizations and think about how we optimize the teams that we currently have. So there needs to be a balance, as we all know. The organizations and the work environments that we work in, especially if you work in healthcare, can be somewhat fluid. Demand can be never-ending at times, it feels, but demand on certain days may be different than other times. So the demand is what needs to get done. We know that. And then the team to do that is who's on staff that day. You know, what time do they have to help us? What about workflow? Is there a way that we can begin to look a little bit more holistically at our approach with team composition, scheduling, and workflow that can help to minimize the stressors of the demands? So as mentioned before, it's extremely important to have all team members working to the highest level of their expertise, their skill, but more importantly, their licensure. Your team, both on a daily basis and overall organizationally, is going to be driven by what the family patient population needs and also the characteristics of your practice. So it's one team in one area may look very different than another team. Every practice has its own personality. And as you said, the characteristics here will help you understand how best to compose your team by the needs of the patients. I would also encourage you to be thinking about the possibility of cross-training to maximize flexibility and flow. I know some practices will have front desk and MA cross-train so that if they're down a staff, they can have people floating back and forth. That's just one idea of a way to help with patient flow while supporting your team. So these are some examples of team redesign, and they are just examples, but ways that you may want to think about the roles that you have now. You may or may not have these roles within your organization, but there are ways to be able to look at each of these roles and maybe adjust them, both for the needs of your patients, but also for the health of your staff. So I'm looking at the registered nurse role here, where you may have nurses that have been direct care staff for a long time. They may prefer to get out of direct care for a while. There may be a care coordination need within your clinic or organization or health promotion. That might be a way to transition somebody into a different role, maybe a case management role rather than a face-to-face every day with patients. Same for medical assistants in terms of workflow and oversight of the chart. You have, again, staying within scope of practice for the medical assistant, but there may be things that they can do to help the team. And then wherever it's possible with behavioral health, if you do have access to behavioral health providers, that they be co-located or integrated in, or there at least be some sort of a bridge that will get patients from your office to the behavioral health care that we need. I will just share with you very quickly one primary care practice that I know in Oregon that was having trouble getting patients who were determined to need behavioral health into a behavioral health professional, is they had case managers actually come in to do a quick behavioral health assessment with the patient and make the appointment for them while they were in the office, still in the exam room. And they found that their follow-up rate with actually getting to the behavioral health professional was extremely high. As before, once they left with a recommendation to go see behavioral health, it was very difficult for them to do that, and the follow-up rates were very low. So what are some of the outcomes that we can have of role clarity and role optimization? So on the left here, we have some of the potential practice outcomes, what you would get from increasing role clarity and potentially optimizing roles, again, around expectations, changes in workflow, which may be improved decision-making overall, where it's more of a team approach, and just less conflict within the office, which is also really important in order to be able to get through our day-to-day. And importantly, on all of these, there are ways that you can actually measure those practice outcomes, and I have them listed here for you. So one way, as I mentioned before, was to, number one, look at your job description, but also potentially rewrite them with an enhanced role and have that be clearly defined with metrics within that process that you can actually track over time, and you can show improvement for your staff. If given a new role, you can track that with this enhanced job description and actually, support them, recognize them over time. Wait times, time spent rooming patients, and also getting out on time, which when I talk to providers is the number one issue, is excessive time in the office. As many providers end up having to go home to continue charting at home, it's extremely important for just about everybody I've talked to be able to get out on time. So when you improve your workflows with this role clarity and optimization, it actually decreases the wait time and can make the workflow more efficient. So that's another thing you can measure. Look at wait times. Look at time spent in the room. Look at time waiting for the provider. And this is a way that you can actually do small tests of change, bring it back to the staff and say, look, this, you all agreed that getting out on time was important, and here's one of the ways that we're going to do that. And then you can run a PDSA cycle for a week or two and see if that works. It's very powerful information to bring back to staff, and they're very grateful that you're looking to make changes, but want to improve things. The other is the use of standing orders, which standing orders have been around for a very long time. I think that they're generally underutilized. One of the things I can think of in terms of standing orders that would be extremely helpful is around vaccines. So if you do not have standing orders in place for all visits, so where I work, we have standing orders regardless of whether it's an acute visit or whether it's a well visit, to review the chart for immunizations, and we've been doing that, and we have increased our immunization rates dramatically because, as we all know, sick visits, people are not always sick when they come in, but they're same-day visits, so you can increase your immunization rates or other rates, as well as satisfaction surveys, both for staff but also for patients. You will see changes if you make some of these changes with role clarity as well as optimization. In talking about all of this and making any kind of change, it's extremely important to remember that what you do must be a shared goal. So remembering that value misalignment leads to team burnout. So the first bullet point here is really key. It's very important to use SMART goals and get stakeholder buy-in, leadership buy-in, as well as using things like run charts to look at what you've done and really see if it's made a change over time. So you want goals that are specific, measurable, actionable, realistic, and then you want a time frame. So just like anything in life, you need to put it within a framework for any changes that you'd like to make so that you can look at it and track it over time. And it's extremely important to do that. Make a decision together, come up with a plan together, and then you can track that. You can do run charts. This is just an example of a SMART goal sheet that you could potentially use. So again, just taking this one step further, be very specific. It's the when, what, where, when, and how this happens, measurable. How are you going to measure it? Is it really achievable? Is it realistic? And how often or when will the goal be met? And in this case, this is something that you're welcome to use to set SMART goals. But it's really important to do this and do this with a team so that you can be successful. This is just a sample run chart, and it could be about anything that you wanted to do. So if you look at the beginning of this run chart at week 1, that is when you start collecting the data. So in this case, they decided to actually bring together an improvement team. So, and that took some time. It looks like that actually took a couple of weeks in order to do that. So the improvement team was formed, had to figure out who was going to be on that team. During that time, they made maybe one SMART goal, and then testing happened over the next couple of weeks. And then based on what they found out, they actually made changes. And then based on those changes, they actually saw a significant increase in whatever the compliance was or whatever it was that they were tracking. If you put up a chart like this and share this with staff and leadership, you will have people's ears and eyes, because this picture can really tell the organization what it is you're doing and why it's important, but more importantly, show that this change actually creates measurable improvements within your setting. So this is just one example of how to do that. Another tool that I wanted to share with everyone that was developed by a nurse at the University of Oregon is something called the ACE15. So this is a good starting point, and this is also open source, so there's no cost, and I have you have the information down there where you can find this. But what it looks at is how do the individual members of your team feel about your team? Do they feel as if they have a cohesive team? So it actually measures something called teamness. And looking at all the things that we talked about, communication, clear roles, goals, that trust, which is an elemental component of this that must be there. It's difficult to be a team without trust. And then what about measurable processes? What about outcomes? And lastly, organizational support. So if you're looking for a starting point as to how to bring this back to your organization, this would be a good place to start. So it would be something to share with leadership, have everybody take the assessment. It goes pretty quickly. It's pretty straightforward. And then you get a sense of where your group feels they are if they're a team or not, which is kind of the very first step that you need to take in order to go on this journey. And so finally, just to recap what we've been talking about today, and we've talked about, improving technology, creating partnerships across the care continuum, and building effective care teams. These are all important pieces of care transformation and the care transformation journey. Administrators and change makers can't forget that patient care is delivered by us, by employees, those who work together. Engaging those employees around behaviors and skills that drive clinical excellence and positive patient experience is going to be a key factor in determining whether a health setting thrives and survives, which we want all of you to do, both to thrive and to survive. So just to break this down and again to give you a little bit of a framework moving forward and beyond burnout, we had talked about the organizational strategies, so the team-based care model. You need to know what type of organization that you have, top up or top down, bottom up. And then think about PDSA cycles using those SMART goals and some of the things you've learned today to create a small test of change. And maybe it's the getting out on time, or maybe it's the amount of time that a patient waits in a room for a provider. It can be something small. When I say small PDSA cycle, I would say no more than 2 to 3 weeks. Then also looking at yourself and your personal strategies and remembering that change starts at home. So thinking about, what you're doing to care for yourself. These are all important questions for you to ask. And with that, I wanted to open it up. I know we don't have a lot of time left, but I did want to open up the line and see if there's any questions from the audience. I know I've given you a lot of information and hopefully lots of resources that you can use. So I'll let Suzanne open it up, see if there's any questions.
Yeah, absolutely. It looks like there's just one question right now. And okay. The person writes, are there any suggested resources that can be used as a resource and outline scope of practice to compare it across different states for all provider types or just one particular provider type?
Yeah, that's a tough one, only because I would say in scope of practice, it could be for, I guess you're asking, or the person is asking for any of the types of providers, so physician, nurse practitioner, medical assistant. I mean, if that's the case, they will vary greatly. So what I would suggest, and again, not knowing which discipline you're referring to, you really need to look at state regulations around scope of practice first and make sure that you're within the state practice guidelines. Now, for nursing and nurse practitioners, it's on a state-by-state basis, so it's going to be very different. For medical assistants and some of the other types of staff in healthcare, it also varies. So that's a tough one with scope of practice. What I would say is maybe look for like organizations. So if you're working in an FQHC, maybe look to another FQHC to partner to look at scope of practice and what may be going on for them, and compare notes. Because scope of practice is a difficult one because you have the legal aspects, but then you also have the practical aspects of what's going on day to day within a practice and how different roles are used within the practice.
Great, thanks, Cheryl. She was just, she wrote a follow-up in the questions box and just said that she is aware of a resource that compares a dental hygienist scope of practice and was wondering if one existed for other type of providers across the state.
That I don't know. And I would certainly encourage anyone who's on the line right now, if you're aware of any of those resources that may be able to do a comparison, if you could chat in the information, that would be great. I know that healthcare, as I said before, is changing it's changed dramatically, at least for me, over the last 30 years, and I expect, the next 5 to 10 years in healthcare to accelerate even more in terms of change with, telehealth, and there's different roles that are coming in within healthcare, and even just utilization of different types of roles. So I do expect the environment and the climate of healthcare to change too, as we have more and more patients coming in. We have all the baby boomers that are aging, and we have one of the largest elderly populations I believe we've had in our history, because people are living longer. So those are all challenges, but not challenges that we cannot overcome by any means.
Great. Well, we have one last question. I know we are almost at time, but just one last question that says, what would you recommend to a provider who is currently in an organization and has tried all of the things that you mentioned to practice self-care and address with leadership, but they still feel burned out? Should they walk away? Would you recommend they seek professional help, or do we ask them to take time off? I guess maybe just a starting point, since don't have too much time.
Yeah, right. So it's interesting that you ask that, because I actually was in conversation with a colleague recently who is experiencing burnout, and we talked about some of the different options at length. One of them was, I call it voting with your feet, which just you give a letter of resignation and you walk out. What happens in that situation if you just leave is that the organization gets no insight as to what the problems are, and potentially if they could make things better in the future for other staff that come in, you lose the opportunity to be able to do that. So first and foremost, I would say make sure you're meeting with the right people. It sounds like you've tried that, and be very clear about what your ask is. So if you're feeling kind of generally burned out and you're, feeling that you're having trouble keeping up at work, then that's a different kind of conversation than you're burnt out and you want to move on to another organization. But I think you need to sit down, make sure that you have your, whatever your issues are, I would put them in writing, share them with leadership, and then think long and hard about what it is that would be helpful for you at this point. Some people do take a leave of absence, and they have time to collect themselves and really think about, is this the work that they want to do? Maybe they need a new organization. I know that sometimes we feel as if we've shared that information with the organization, but may not have been heard, which is why it's important to put that in writing. But think about options that would work both for you, but also for your organization. So make sure it's addressed, make sure you get the help that you need, think about options that you would like, and certainly taking some time off might be a good option. But again, it's something you need to talk to your practice about, but you should feel supported in whatever decision that you make.
Great. Well, thank you so much for answering all of those questions and for being with us today, Cheryl. We really appreciate it. Cheryl's contact information is in the slide here. And I just want to mention, because we had a couple questions about it, the handouts are currently in the handouts tab on your go-to toolbar, and they will also be emailed out to you after this. So they are available, because I know there's some really great resources there. So as we wrap up today, I just wanted to remind you guys there are 3 upcoming webinars remaining in this series. And next week, Cheryl Fattibene will be back with us, and it's actually on a Wednesday this time. So it's still from 1 to 2 Eastern, but it is on Wednesday. And so the dates are there, and you will be sent a go-to reminder for that. So you'll be reminded from the system view as well. So thanks everybody for being so attentive today and your great questions. And again, to Cheryl for being with us and providing great insight and resources for everybody on today. Thanks so much, everybody. Take care. Bye-bye.
My pleasure. Thank you.
Thank you.
Bye-bye.